From the campus of the University of Nebraska at Omaha. Consider This, a program of issues and information behind today's news.
So our goal through the use of this grant is to reduce the prevalence of prediabetes, to keep people out of the hospital, and again, to create a longer, healthier, more successful life.
Hi everyone, I'm Kathy Wyatt. Welcome to the 25th season and this week's edition of Consider This. Our topic, diabetes on track. We have two guests from UNMC joining us to talk more about it. The first is Leslie Island. Dr. Island is an assistant professor of medicine in the Division of Diabetes, Endocrinology, and Metabolism. Next to her, David Jeweltowski. Dr. Jeweltowski is one of two principal investigators for the program that UNMC Chancellor Dr. Jeffrey Gold referenced in the opening video. Thank you both for being here and welcome.
Thanks for having us.
Great to be here.
You bet. Dr. Island, let's start with the basics. What is a chronic condition?
So a chronic condition or chronic disease is it's a medical diagnosis or condition that we expect to last a very long time, quite possibly the rest of your life.
Okay, and diabetes in the top three following heart disease and cancer.
Correct.
When people ask you to tell them really what diabetes is, how do you explain it?
That's a good question. So diabetes is a condition that affects how food is metabolized and converted to energy. It affects how your body converts food to energy. So when we eat, many of the foods that we eat get converted to glucose, which is a type of sugar. And then that sugar gets into our blood, into our bloodstream. And in somebody without diabetes, you have an organ called the pancreas, which is in your stomach, in your abdomen, and that makes a hormone called insulin. And the job of insulin is to push the glucose in from the blood vessel into the cell so the body can use it for energy. And when you have diabetes, that system is disrupted. So you either aren't making enough insulin or you're making enough, but your body's just not responding to it, and it's not able to use that glucose that came from food for energy.
Okay, and we're going to put up a graphic for our viewers, and while we do that, talk to us about how many Nebraskans are affected by diabetes.
Yeah, so almost 10% or 9.6% of Nebraskans have a diagnosis of diabetes, and just over a third, I think about 36% of Nebraskans have pre-diabetes, which is where you have some sort of abnormal blood sugars. They're not abnormal or elevated enough to qualify for diabetes, but they're also not in the normal range either.
Okay, and there are different types
of
diabetes. Walk us through those.
Sure. So one type is gestational diabetes, which is diagnosed during pregnancy and often goes away. Your blood sugars improve after the woman delivers the baby. But people with a history of gestational diabetes are at increased risk for type 2 diabetes later in life. The other two main types would be type 1 and type 2 diabetes. Type 1 diabetes is more rare. It's probably about 10% of people with diabetes. We classically think of it being diagnosed when you're a child or a teen, but it can actually be diagnosed at any age. And that is an autoimmune condition where you have antibodies that are attacking the cells of the pancreas, the beta cells, which are the cells that make insulin. And so when the antibodies attack those cells, they no longer produce insulin. You're not able to push that glucose into the cells like you should be, and so you need insulin for the rest of your life. Type 2 diabetes, so much more common, this is what we're talking about today, is not necessarily a disorder where you don't make enough insulin. Early on, you make plenty of insulin. It's just that your body is resistant to it and your tissues aren't able to utilize the insulin. So you're making enough, you're just not able to respond to it appropriately. And so early on, it's a much slower process. So early on, if it's recognized, we can manage it with diet, with exercise, with weight loss. As time goes on, we may need some additional medications, some non-insulin medications. And after having type 2 diabetes for a number of years, some people do ultimately require insulin.
Wow, Dr. Jeweltowski, she did a great job explaining all of that. And she did bring up the word manage, which I want to talk a little bit with you about. Not having diabetes, I don't understand the absolute challenge that folks can have managing this disease. I mean, you can't talk to a person, you know, and find out that somewhere along the line they were having trouble managing what has just been described here. What are the main reasons for that?
Well, when you think about management, I think you need to think about the title of our project. So we picked On Track specifically to think about this track from being a normal, healthy person to slowly moving into prediabetes to slowly moving into diabetes. And part of what's important to understand about that is the patient is in the center of that. So the patient's making decisions about healthy exercise, about healthy eating, and those decisions are high frequency decisions, as you know. All through the day, you're making decisions about, am I active or am I eating healthy? And you know, when those accumulate, obesity accumulates when those decisions are bad. So you get on the bad track rather than being on the good track. So how can we get people on the good track? Now, it's what I just talked about was diabetes being a patient decision, right? But we know diabetes varies by where you live. And what that really means is where you grow up and where you live creates the opportunities for you to be active and the opportunities for you to be healthy. And also in this project, the opportunities to actually seek care and seek more advanced new technology coming out. So that's what manage means. Early on, it's not really management, it's prevention. But then when you move into diabetes, it becomes management. Managing decision about what to eat, managing decisions about when to be active, and then having some cool stuff she does with remote glucose monitoring, new technologies that make that easier.
But isn't, you know, as you're talking, navigation, I mean, we have a pretty complicated system. And so when you start to, you know, trip over the navigation piece, then it's not quite as clear in terms of the resources you're seeking. I mean, talk with viewers about that, because I think there's probably everybody watching, whether it's diabetes or something else, is saying, yeah, it is kind of tough to do that sometimes. I don't even know the first call to make. So talk a little about that.
So first of all, let's think about the pre-diabetic. And when we think about that, actually think about being out in the community and not realizing you're diabetic. So a pre-diabetic, excuse me. So kind of the first step on that pathway is starting to get assessed and learning, you know, am I pre-diabetic or not? And that means engaging with the healthcare system somewhere to find out if that's true. And when you find out if that's true, then it's navigating the myriad of resources out there. And you know, in today's society, you hear things every day. You hear this show, you hear the news, you hear popular culture solutions, and often those solutions and that information might not be what Dr. Island would suggest is the best evidence-based practice for medicine. And for communities and clinics and public health departments and grocery stores and pharmacies, you know, they're all not coordinated, right? They're isolated. So navigation becomes moving from that healthcare system to figuring out where I can get things, how to access those resources. In, you know, large health systems in metro areas, sometimes those are all aligned, right? You go to your doctor, you go to your diabetes prevention program, you go to your pharmacy, it's all linked. In rural areas, they're not so linked always. You have to cut across health systems and different agencies to receive those. We'd like to keep care local because we know if those things are locally accessible, it's easier for patients to make decisions.
I want to go back to your explanation of Diabetes on Track a little bit further than that in terms of how this came into play at UNMC and Nebraska Medicine, because we're just catching wind of this now, and I understand that they received some funding. Talk a little bit about that.
Well, it's interesting. Some passionate people back in the 80s started to do some work around diabetes education. And what that led to was the creation of the Diabetes Care Foundation of Nebraska, and Dr. Tim Wall and some other key people decided that they wanted those efforts to carry on. They wanted people in Nebraska to start to embrace this idea. And they gave this great gift of money to UNMC to help us organize UNMC into what we're calling a patient-centered hub of expertise. So we're trying to bring in all these different areas. And if you just heard today, it's not just, endocrinology. It's a number of different fields that have to address how we novel solve this problem. And also tied to that was then, can we pilot or demonstrate over a couple years in a couple rural Nebraska communities a novel approach on how this would be a Nebraska-owned local solution, rather than taking a top-down solution that might work somewhere else, making sure it builds on what we know might work in Nebraska and what local people believe would work.
Okay, so your role in all of this is what then?
So I'm one of the principal investigators, and that really has a couple roles in my case. One role is to try to bring together the team. How do we bring in people who might be experts to this patient-centered hub? A second role is kind of to try to create this vision. Part of my expertise has been around creating a populational health change, a community change, a whole community change, what that really means is reducing the number of pre-diabetics in a community. And so I bring together, that becomes really kind of a social community problem. So I'm both kind of a manager as PI, and then also bringing this technical expertise on public health, whole community change.
Okay, that's a big job.
Yeah.
So as you're talking, and sometimes I do when guests are speaking, I think, why on earth did they get involved in doing what they're doing? So what brought you to this point in your career?
Oh, that's real interesting, actually. I was actually a college distance runner and found the importance of physical activity, and I was interested in science. So I went on a track of becoming a scientist that studied physical activity. What that led to was me actually marrying a small town Iowa farm girl from a town of 5,000 and ending up staying in the Great Plains area. We lived in Kansas, we moved to Nebraska a few years ago, and just developing this passion about rural communities. And starting to realize through years of NIH funding and a research career that physical activity, healthy eating were really important behavioral problems that rural communities faced, and bringing that expertise to this problem. And it's a novel expertise. A lot of people don't have expertise in rural communities, social science, and really technical knowledge about the health behaviors.
Well, it's an interesting skill set that you have, because you had mentioned that you really do need to know Nebraska in order to do this properly, right? So as you were doing your homework and you continue to do that, what are you finding? Talk with our viewers a little bit in terms of, I mean, you're going through, we got to remember that. Oh, and this is important for us to know too, especially when it comes to this project. What were those ahas for you coming into this?
Well, when I started this research career early on, right, we thought we were going to find the golden solution, right? The one, I used to call it the one-size-fits-all golden ticket, right? And of course, when you get a PhD and you're a scientist, you think you can come up with that solution and bring it to people, right? And we quickly learned that this is what we might call a wicked problem or a high-dimensional problem, a local problem, in the sense that there's a lot of different things that drive whether someone in rural Nebraska in a town eats healthy, is active, prevents obesity, right? And then if you look at the healthcare system, just across Nebraska, it's different in every community. So what we kind of learned then is we need to work locally with local knowledge and let them lead change and let them make their own decisions to build their capacity both as a community and and the people leading these different organizations to do what's best for their community and the best for the individuals. And so that becomes not telling people, but really providing them with evidence-based information and a framework to enhance their decision making. And it's exciting because I think what we'll see in this study, and we've seen it in our other projects, is local communities will find triggers locally that are barriers and opportunities. And that will lead to more people being active and more people eating better. And we may solve why some people get diagnosed for prediabetes but never engage the system anywhere else. We call that kind of the patient pathway. So the flow of that individual through what we kind of call the community system, linking into that healthcare system, figuring out how to coordinate all that for both the community and for that patient is key. And patients need help too. So we're going to look at how to have someone locally, we call it a community health worker, with some expertise to help the patients navigate.
Okay, and you were talking about patient pathway. I want to put up a graphic for our viewers now because you're talking about the approach, and any approach needs to be supported by something, right? And in your case, you're the ones doing that action. But as you look at this graphic, this local data-driven approach, which is talking directly to what you just said, what are we seeing on there, doctor, that is important for us to know that you haven't already mentioned, that you haven't already addressed? Is there anything there?
Well, one key thing is the first one, I think, is the data-driven decision making. And so what that really means is we don't really know how the level of prediabetics and diabetics in a community, right? Health systems are isolated, so the first step is really having an understanding of the problem, because then that can mobilize the community to have a better understanding what it is. So when we say data-driven decision making, we're really talking about community leaders, clinic leaders, pharmacies, having a better understanding of how to make their decision with their local information. But also what's really neat is technology is becoming available for patients to have access to data now. And even real-time data on glucose. So that is providing opportunity for data-driven decision-making by the patient as well. And when you give people data and don't make decisions for them, but just explain to them what the data is, then they're informed to make their own decisions.
Very good. And I know there's a pilot project to be launched in the fall, Dr. Eiland. Now, earlier you mentioned that type 2 diabetes was going to be the focus here. So tell us a little bit before we drill down, just big picture, what is this pilot project going to entail?
Sure. So I'm a practicing adult endocrinologist, and so I'm in charge of the clinical aspect of this program. So right now we are working with a number of clinics in Hastings and one clinic in Wayne, and just getting familiar with these clinics, getting to know them, figuring out the makeup of their clinics, who's part of their team, what's going well, what's not going well, and doing what we're calling a needs assessment, figuring out if you could pick something to improve how you care for your patients with prediabetes and type 2 diabetes, what would it be? And we're hoping with the clinical aspect of this project to empower the providers to utilize some of the more newer agents or newer medications for type 2 diabetes. We'd also like to see an increased use in diabetes technology like continuous glucose monitoring. And we'd also like to increase the number of people in that clinic beyond just the physician that feel comfortable and are able to provide diabetes education to those patients.
Wow. Okay, so why Wayne and Hastings?
So we initially were asked to pick two communities, one smaller, closer to 5,000 people, one more mid-sized, closer to 20,000 people. And so we looked at those options. I do a lot of telehealth, and my group has had an endocrine telehealth program at Mary Lanning, the hospital in Hastings, for almost 10 years now. And so we're very familiar with those physicians and have good relationships with them. And data played a role in that as well. So the clinic in Wayne and several clinics in Hastings have the same electronic medical record that the University of Nebraska does. And so we're able to get more data from those patients. And in order to prove that this program is successful, we need data showing that. And this is the best way to get it.
So, Dr. Eiland, talk to us a little bit. We're a few months out of this pilot. So what is it that someone like you loses sleep over at night in terms of just that whole preparation piece? I mean, we're going to get to a certain point, and on that timeline, this is when you're going to need to be able to do, you know, X or whatever it is, right? X, Y, or Z. What are you thinking about right now? What's the focus?
I'm thinking about balancing a consistent curriculum to provide to all the clinics across the board to make them feel comfortable managing the people with diabetes that they care for, but I'm also bearing in mind that we need to take a very individualized approach. Each community is different, and within that, each clinic is different in terms of what their resources are, what their patient population is like, and so while there may be some elements of the project that are very consistent across the board, we imagine that each clinic will sort of have an individualized program as well. So it's just a balance.
Okay, what else about the process, especially now that we've gotten the attention of those two communities, right? What can they, the residents, expect in terms of this process? It's going to launch in the fall, but how long will it go on? That kind of thing for those living there.
Yeah, so we're hoping for the next 2 to 3 years that they notice an increase in community resources led by David and his team. So more interventions around healthy food options, physical activity and exercise. For the patients, or for the people that have primary care providers within those two communities, we're also hoping that they see, some newer medications being utilized. They see providers talking more about diabetes technology, and they're seeing just an increased number of people within that clinic talking to them about diabetes and being willing to provide diabetes education.
You may have hit this a little bit, but okay, so you're going to go into these two communities and you're going to educate the educators, right? In hopes that the individuals will have better lives. You're trying to enhance lives here. Are you then going to take some of those professionals and plug them into communities down the road if you should do something similar so that they can help you educate the other? Does that make sense?
That's a good question. Yeah, so we're utilizing a curriculum based on a Project Echo design, which is where you have a multidisciplinary team at UNMC. We have a team of social workers, behavioral health professionals, pharmacists, general internal medicine providers, endocrinologists, nurses, and dietitians that are all working together to provide some sort of structured curriculum. But we're also hoping that over time, when the clinics also participate in this curriculum together all at once, that they start educating each other, and we don't have as much to say because they're becoming the local experts.
Collaboration is huge. We've talked a lot about it on this program in terms of the benefits that it provides. Do you anticipate, other than maybe the communication piece, much in terms of obstacles? I mean, in an ideal world, collaboration, when it works, it's beautiful.
Right.
But you are dealing with a lot of moving parts, in this case, people. And so what are you expecting there?
So, I mean, there's certainly challenges with the workforce and a shortage of nurses and medical assistants and patient care techs. And so that's a challenge when we're trying to post a new position or hire someone to become a new nurse in a clinic that's going to provide diabetes education. We have to wonder where, who's going to fill that position because there's plenty of other open positions in those communities. So that's certainly something we're nervous about.
Okay. Doctor, I want to go back to big picture in all of this. So she's talking about a project to be launched in the fall. This is 3 years, is that what I'm understanding?
It's a 3-year grant, 2 years in communities, yeah.
Okay, so we're going to put 3 different slides up for our viewers. And as we're doing that, please just let our folks know what's important to note. Again, we're statewide, so we'll put the first one up. In year 1, walk us through here.
So what we're doing is our team has a community team, a healthcare team, and a patient pathway team. So those teams are getting involved with the communities. Leslie's targeting clinics, and so we're public health folks, so we're hitting the public health departments that are local, and they're helping us frame what the project means for those communities. So we've selected 2, and we hope to launch in August.
Okay, next one, year 2.
So, you know, we can try to put this project in phases. Implement, monitor, evaluate might be a way to say phases. But what that really means is we're going to try to spiral up the capacity of the communities, the clinics, the health departments to create change through implementing changes. And while we do that, we're going to monitor those changes, and simultaneously we got that data so we can evaluate what's happening and give that data back to the communities.
Okay, wonderful. And then this is our final, year 3.
Hopefully we're going to have some learned from year 1 and year 2, I should say, here, and make corrections and continue that process. And I think long term, there's 2 outcomes, or maybe even 3, that the Diabetes Care Foundation would be happy with. I think one outcome would be building the capacity of UNMC and Nebraska Medicine to reach out and engage. And that's something we do, but it's certainly helpful to bring diverse groups together to do that. The second is to pilot out some novel things in these 2 communities that are similar to a lot of communities in Nebraska. And I think what we're getting at with that third goal is, how do we take those lessons, and you brought it up, spread those lessons across other communities? And that's going to require more resources and more funding and more people involved that find this as important.
Okay, talking today about something called Diabetes on Track to launch this fall. We have about 15 seconds. Final thoughts, Dr. Eiland.
I would say we're just so thankful for this gift. I think it's rare to receive such a large donation to focus on rural diabetes, and we really just want to be good stewards of it.
Wonderful. Folks wanting more information, we're going to put a graphic up just in case they are wondering. This is great. Diabetes on Track at unmc.edu, or you can just call the main number 402-559-4000. I want to thank you both for sharing your time and your expertise, and I want to wish you the very best with this project. Thank you so much.
Thank you.
You bet. And thank you all for watching. We'll see you next week.
Consider This is an issues and information program produced by UNO Television. More information and program archives can be found at nebraskapublicmedia.org/considerthis. If you'd like to share your comments about this program, call UNO Television at 402-554-2516 during regular business hours, or send an email to cwyatt@unomaha.edu.